Students, coming to the most interesting disease. So because of this disease, 5 lakhs per year, 1,400 per day, 1 death per minute is happening. So these are the number of deaths happening because of this disease, especially in our country. So what is that disease? Yes. So it is tuberculosis. So just like Thanos, it can wipe off generations. So it is king of all infections, TB bacilli. Even though now many are discussing about COVID, but this tuberculosis is since 3000 years, still we are not able to get control over it. Now, first of all, let us see what is presumptive TB. So a patient with any one of the following. Any one of the following features. So any one of the following features. So what are they? Fever more than 2 weeks, cough more than 2 weeks, hemoptysis, significant weight loss, and also any radiological abnormality, on the chest X-ray suggestive of tuberculosis. If you find a patient with any one of the following, such as fever more than 2 weeks, cough more than 2 weeks, hemoptysis, significant weight loss, radiological abnormality on chest X-ray suggestive of TB. So this patient can be presumed to have TB. So now it is called as presumptive TB in our country. So it is a patient with any one of the following. Now you have found out a patient presumed to have TB. What should be next is the algorithm for TB diagnosis. So write down the algorithm for TB diagnosis. So this is the recent algorithm that we should follow. Now you have identified a patient presumed to have TB. So first you need to know whether this patient belongs to general population or he is belonging to some special group. So who are the population coming in this special group? So it is symptomatic HIV. So there is a patient with HIV and he is having symptoms such as fever, cough, etc. So symptomatic HIV and symptomatic extrapulmonary TB. So there was a patient having lymph node TB. So now he has developed some cough. So pediatric patients, symptomatic pediatric patients. So symptomatic contacts of pulmonary TB. Symptomatic diabetes mellitus. So symptomatic diabetics. So symptomatic patients who are having cancer. So symptomatic patients who are malnourished and symptomatic in patients who are on immunosuppressants. So these are some special group of population where the chances of TB happening is very, very high. So first you should know whether this population is belonging to general population without any of these comorbidities or any of these special features such as having HIV, extrapulmonary TB, pediatric patients, contacts of pulmonary tuberculosis, diabetics, cancer patients, malnourished, and patients on immunosuppressants. So if the patient is belonging to a general population, so what are the initial tests? So initially I send him for sputum examination. So sputum smear examination. So we have to send him for sputum smear examination. And also simultaneously I should advise a chest X-ray. So sputum smear examination and simultaneously I should advise a chest X-ray. After some time, I am going to get the results of this test and I am going to compile the results like this. So in the first scenario, patient might be smear positive. So if the patient's sputum smear is positive for sputum smear examination, so if it is positive for acid fast bacilli, irrespective of the chest X-ray, it may or may not show tuberculosis. So irrespective of chest X-ray, it may or may not show tuberculosis. So this patient we should consider as microbiologically confirmed case. Microbiologically confirmed case. So what I should do now is I should perform nucleic acid amplification test. If it is available, immediately I can perform and start treatment accordingly. So according to new guidelines, any TB notified patient, any patient whom you are notifying as having TB should get a NAT done to see whether the TB bacilli is sensitive or resistant to rifampicin, because nowadays drug resistant tuberculosis is becoming a very big problem. If you identify it early, you can treat it better. On the other hand, patient's smear is negative, but chest X-ray is strongly suggestive of TB. According to new guidelines, here also we should go for NAT. Now, if the patient is belonging to a special group, so the first test here for identification of tuberculosis is NAT. Now, what is meant by NAT? So, NAT means nucleic acid amplification tests. So, these are molecular tests which will not only identify TB but also rifampicin sensitivity. So these tests will identify TB and also rifampicin sensitivity very rapidly within few hours. So within few hours. So now we are having two types of NAT. So previously it was only CB NAT. So CB NAT. So the other name for CB NAT is gene expert. So we know what is meant by NAT. Nucleic acid amplification test. So what is meant by CB? CB means it uses cartridges. So it is a cartridge-based nucleic acid amplification test. So that is American technology. Now coming to our own technology, it is True NAT, nucleic acid amplification test, and True is the name of the lab. So Indian Desi technology, very simple version and cost effective is TrueNAT. So according to the national program, so you can perform any one of the following, either CBNAT, also called as Gene Expert, or TrueNAT. Now in the new guidelines, performance of NAT has become very important. Now, if you see at any point of time, ultimately I have to perform nucleic acid amplification test, and I have to identify tuberculosis and also rifampicin sensitivity. So because NAT has become such important in the diagnosis of tuberculosis and planning a treatment regimen, they have extended the diagnostic algorithm. So once you have done NAT, you are going to get a result. So whether there is TB, yes or no, and is that TB bacilli sensitive or resistant to rifampicin. So after doing that, how to proceed further. So this is the extended algorithm given in the new guidelines. So very simple. Just follow this algorithm. It is very easy to understand. I will highlight the important points. So now I have performed NAT and I have found that there is TB. Now next thing is I should know whether it is rifampicin resistant or rifampicin sensitive. So we have two categories. So rifampicin resistance not detected. It means rifampicin will work very well here. So this is the most common category. So most commonly we get rifampicin sensitive TB bacilli only. So once you have found out that this TB is rifampicin sensitive, what you should do next? I should start drug sensitive regimen and I should send for first line LPA. Now try to understand this. This is not at all complicated. Just to follow me. Once we read tuberculosis in detail, you will understand this very well. So start DS regimen means drug sensitive TB regimen. So according to new guidelines, we have classified TB treatment into two: drug sensitive TB, drug resistant TB. So drug sensitive regimen is the conventional regimen containing HRZE. So that I will discuss in the treatment part. Now just remember, we are starting the conventional drug sensitive regimen, and you should send the sample of the patient to first line LPA. So LPA for FL means first line drugs. LPA means line probe assay. Line probe assay. So what is this FLLPA and what is the need for sending for this LPA? See, LPA is line probe assay. It is also a molecular method, just like your CBNAT. It will detect TB and it will also detect resistance to other drugs such as isoniazid. See, we know that in CBNAT, you can identify resistance to only one drug, that is rifampicin. Even in TrueNAT also only rifampicin. But recently we have found out there are some strains of TB bacilli where it is sensitive to rifampicin, but may be resistant to other drugs such as isoniazid. See, we are having four first line drugs. I think most of you must be knowing first line drugs: H, R, Z, E. So these are the first line drugs. So H stands for isoniazid, R stands for rifampicin. This everybody know. Z stands for pyrazinamide. Z stands for pyrazinamide, and E stands for ethambutol. So recently we have found out, so some strains may be sensitive to rifampicin but might be resistant to isoniazid and other drugs also. But routinely we are doing drug sensitivity in LPA to isoniazid at least. So now I need to know whether isoniazid works here or not, because if isoniazid is not working, so there is no point in continuing isoniazid. Instead of isoniazid, I can add other drug. So what I do here is I am going to start the drug sensitive regimen and I will send for first line LPA. Now after few days, the result will come out. So if the result says H resistance not detected, it means H is working in this patient. So H is sensitive. So this TB bacilli is sensitive to isoniazid. So there will be no issue. So I can continue the first line treatment. So no problem because H is working here, R is working here. So two important drugs are working here. So I can continue the first line treatment. Now, if at all, H resistance is detected. Now, this is something problematic. Now, here, isoniazid will not work in this patient because the TB bacilli is resistant to isoniazid. So, what I should do? I should start isoniazid resistant TB regimen. Here rifampicin is sensitive, but isoniazid is resistant. So I'm going to start that regimen. So whenever there is H resistance, what is the regimen that I am going to start is, so whenever there is H resistance, I am going to give a regimen. So instead of H, I am going to add levofloxacin. So I will add levofloxacin. So instead of H, I am going to add levofloxacin. So this H is removed. So we are going to add levofloxacin. So we are going to add levofloxacin. So what I am going to do? So I am going to start H resistant treatment. So there is a regimen for H resistant TB. So that we will discuss in the drug regimens. So that treatment I am going to start. And now what I am going to do? Now I don't know whether this levofloxacin that I have added, whether this will work or not. So for time being, I have added levofloxacin, but I exactly did not test the efficacy of levofloxacin in the given TB patient. So what I am going to do, I am going to send for second line LPA. So I am going to check whether this TB bacilli is also resistant to any second line drugs. So second line drugs in the sense you must be knowing. So what are the second line drugs for tuberculosis? Fluoroquinolones, aminoglycosides, all those. So I'm going to send for second line LPA. And if they ask you which is more accurate for knowing the drug resistance, so it is culture. See, if you see in microbiology in the second year, so we do a technique called as culture and sensitivity. So culture might take more time, but it is more accurate. So here, once the TB bacilli is becoming resistant to many drugs, I need to know accurately what drugs will function on this TB bacilli. So usually I subject it to liquid culture. So liquid culture, the results will be out in 1 to 2 weeks, whereas solid culture, it will take about 8 to 10 weeks. So I go for liquid culture drug susceptibility testing. So LCDST means liquid culture drug susceptibility, liquid culture drug susceptibility testing. So I am going to grow the TB bacilli and I am going to test whether this TB bacilli is sensitive or resistant to the second line drug. See, suppose I have started levofloxacin, rifampicin, pyrazinamide. So this regimen, levofloxacin, rifampicin, pyrazinamide, ethambutol in this patient. And after a few days, I have found out this TB bacilli is also resistant to levofloxacin. So there is no point in giving levofloxacin. I have to add any other alternative drugs. So you have to start H resistant treatment and you should send for second line LPA and liquid culture DST. And once the results arrive, so immediately you should modify the regimen according to the results. So if in the results, if everything is sensitive, all the second line drugs appear to be sensitive, levofloxacin sensitivity is there, you can continue levofloxacin. So if levofloxacin is resistant, you have to go for alternative drug. So if any additional resistance is found, you should modify the regimen accordingly. So this is the extended algorithm according to the new guidelines. So once resistance to rifampicin is not detected, you start the drug sensitive regimen and you see whether this patient is having isoniazid resistance. If there is no isoniazid resistance, you continue the conventional HRZE. If there is isoniazid resistance, you start levofloxacin based regimen and you see whether levofloxacin is sensitive or resistant. If if the TB bacilli is resistant to levofloxacin, you are not going to use levofloxacin. You will modify the regimen. Now coming to the other hand of the diagnostic algorithm, so which is very problematic, that is rifampicin resistance is detected. So rifampicin is the most potent first line antitubercular drug. So if you find a TB bacilli resistant to the strongest or very good drug available, it will automatically be resistant, or it may be resistant to multiple other drugs. So here you should identify the presence of additional resistance very early. So what is the algorithm here? So immediately you should send for all LPA, first line, second line LPA, because rifampicin is the most potent drug. So if the TB bacilli has become potent against the strongest drug, you should also check whether this TB bacilli is resistant to other first line and second line drugs. So because this is a warning sign, so TB bacilli has become resistant to rifampicin, it means it might become resistant to multiple drugs. So if you find out what are all the drugs that TB bacilli is resistant early, so you can remove those drugs and you can design a regimen where TB bacilli is sensitive. So send for first line, second line LPA and also liquid culture DST and plan treatment. So what you do is you send the sample to see whether it is isoniazid resistant. Is there levofloxacin aminoglycoside resistance? So same thing for accurate finding, you also send it for liquid culture. So meanwhile, you cannot deny the patient treatment. You are going to plan the treatment. So what you are going to do, you see whether there are any exclusion criteria for shorter MDR-TB regimen. Actually, for MDR-TB, so drug-resistant TB, rifampicin resistance and MDR-TB, the treatment will be the same. So there is a shorter regimen, but this shorter regimen cannot be given to all patients. There are some exclusion criteria. If any one of the exclusion criteria is present, you will avoid the shorter regimen. Instead of that, you will give longer regimen. Say longer regimen is for about 18 to 20 months, whereas shorter regimen is only 9 to 11 months. You should only give shorter regimen when there are no exclusion criteria. So once we discuss the treatment part, I will clearly explain you what is shorter regimen and what is longer regimen. So now exclusion criteria for shorter MDR-TB regimen. If it is present, what you should do. If it is absent, what you should do. So if there is any exclusion criteria, you should not give shorter MDR-TB regimen. You should go for longer MDR-TB regimen. So here you can start longer MDR-TB regimen. If at all there are some exclusion criteria, you should go for longer MDR-TB regimen. If there are no exclusion criteria for shorter MDR-TB regimen, you can start the shorter MDR-TB regimen, because for shorter MDR-TB, you should exclude some population. So if there is that population, you cannot give shorter MDR-TB regimen. You should directly go for longer MDR-TB regimen. So if no exclusion criteria present, you can start shorter MDR-TB regimen. If exclusion criteria is present, you start longer MDR-TB regimen. So you will be initiating the patient on this treatment. After few days, the drug sensitivity will come out. Accordingly, what are all the drugs resistant, you are going to exclude the drugs and you are going to add alternate drugs. So ultimately, you start any one of the regimen and you wait for these results. So the LPA results to come out and also the drug sensitivity testing by liquid culture. So first the LPA results will be out. According to that, you can modify the regimen, and the final result is liquid culture DST. So when it also comes, so if there is some discrepancy, you follow what is there in the liquid culture drug sensitivity. So what are all the drug sensitive? You try to accommodate them in the regimen. You try to remove the drugs which are resistant. See, once if the drug is resistant, if the drug is not working, what's the point in giving it to the patient? It will only just increase the adverse effects. So in case of any additional resistance, you can modify the regimen. So try to understand this simple algorithm. So NAT has become very important in the diagnosis of tuberculosis and also planning the treatment regimen. If there is resistance detected, it means more chances of this TB bacilli being resistant to all other drugs also, because it has developed resistance to a strong rifampicin. So you send for first line LPA, second line LPA and liquid culture DST. So you have to check whether the first line drugs are working or not, second line drugs are working or not. So by the time results come out, you need to initiate the patient on some treatment, and depending upon the patient criteria, if he fits to shorter MDR TB regimen, you can start the shorter MDR TB regimen. If he doesn't fit into that shorter MDR TB criteria, you can go for shorter MDR regimen criteria. If he doesn't fit, you can go for longer MDR TB regimen. So once the results of LPA and this drug sensitivity testing come out, so once the sensitivity of the drugs come out, so you can adjust the regimen accordingly. So this is the new algorithm, extended algorithm for drug resistant TB. So this is also called as the integrated algorithm. So very, very important for your exam. Coming to the other new updates. All TB cases should be notified to the government. So once you have identified a patient to have tuberculosis, not only in the government setup but also in the private setup, you should inform it immediately to the government. So if you don't inform, so there can be legal action against you. And you should provide universal DST to all notified TB with upfront NAT. So that was the thing that we have discussed. So let it be any TB patient. As of now, you should provide him NAT so that you can identify whether this patient is harboring a drug sensitive tuberculosis or drug resistant tuberculosis, to provide universal DST. So that is called as universal. To all you are providing drug susceptibility testing. You are seeing whether the TB bacilli is susceptible to the drug, yes or no. And what are the NATs that we are having now? See, the older one, the American technology, it is CB-NAT, also called as Gene Expert. So you can see a big bulky mission like this. Whereas Make in India, Indian made handheld micro PCR device, India made. So what is this technology or device called as? It is called as TrueNAT. Actually, the efficacy of both missions are nearly the same. That is the reason the national program has included both in the diagnostic algorithm. So you can use any one of the following. Now, what is the most important differences between these two? It is the same difference as a difference between a desktop and a laptop. So you must be seeing in the olden days, so there were very big computers which were attached to the your desk. You'll have a big CPU. You need 24 hours power supply, and it is not portable. In the same way, Gene Expert is also a big bulky mission, and it requires 24 hours of power supply. You cannot carry it here and there. Whereas this TrueNAT, so this TrueNAT is actually a handheld device. So just like laptop, you can carry your laptop anywhere, and your laptop does not require 24 hours of power supply. It is battery powered. So once you have some charging, it can work anywhere. So this TrueNAT mission is a portable handheld, does not require 24 hours of power supply. So you can use this even at the level of your primary health centers where there may not be continuous power supply. So CBNAT or GeneXpert, just like your desktop, so big bulky mission. So it is not portable. It requires continuous energy supply or power supply. Whereas TrueNAT is just like your laptop, which is a handheld, portable, and it does not require 24-hour power supply. It can be maintained by the battery. So these are the new updates. All the TB cases should be notified, and one should provide universal DST with upfront nucleic acid amplification test. Now, recently, what they have done, this is a trend happening in our country. So, when something fails, you change the name of that. So, it is like Thanos becoming Tanish. In the same way, RNTCP, Revised National Tuberculosis Control Program, they found it is not working properly in our country. Something has to be done. What is being done? The name has been changed. So, what is the new name? It is National TB Elimination Program. So, nowhere you should use the name RNTCP. Now it has been removed. You should call it National TB Elimination Program. Still, if you use RNTCP, you will be called as anti-national. So now it is the National TB Elimination Program. So that is final. So whatever guidelines that I discuss, diagnostic algorithms that I discuss here, all are with respect to NTEP only. So all these are with respect to NTEP, National Tuberculosis Elimination Program. Now let us see what is this concept of primary TB and secondary TB. As the name indicates, primary TB, it is first time. It is first time infection with TB bacilli. So when somebody inhales TB bacilli for the first time, so by virtue of ventilation and gravity, so we have discussed where is ventilation highest in the lungs, mid and lower zones. So TB bacilli reaches the mid and lower zones. So most common site will be the mid and lower zones because these are the areas with highest ventilation. Now this area of initial infection. So this area of initial infection, it is called as Ghon's focus also called as primary focus. So this area of initial infection, it is called as Gons focus, also called as primary focus. Now, point to be noted here is this primary TB in majority happens in patients with good immunity. So, where is immunity generated against TB bacilli? It is at hilar lymph node. So, there will be hilar lymph node enlargement to fight against TB. Now, this combination of parenchymal focus with lymph node enlargement, it is called as primary, also called as Gons complex. I told you this TB actually happens, this type of TB actually happens in patients with good immunity. Because there is good immunity, this immunity destroys majority of TB bacilli. So even if the patient coughs out, there will be less bacilli coming out. So this patient will be less infective form. So he will be less infective form. And in majority, there will be spontaneous or resolution. So there will be spontaneous healing or resolution by virtue of body's defense mechanisms. So spontaneous healing and very rare complications and very rare complications. Whereas secondary TB, so this happens either due to reactivation or reinfection. The first prerequisite here is body's immunity will be slightly deranged. So there will be reduction in body's immune phenomena. So whenever body's immunity reduces, so where will TB bacilli reach? So TB bacilli reach apex and actively grow. So why do they actively grow in the apex? We have discussed in the topic initially in respiratory medicine. You can refer your notes, ventilation perfusion ratio. So the apex is filled with more oxygen and TB bacilli require more oxygen for their growth. So whenever body's immunity is reduced, so let it be wherever TB bacilli are there, they will reach the apex and actively grow. So because of their active growth, there will be areas of destruction. So these areas of destruction are called as cavities. So there will be areas of destruction, especially in the apex of lung, cavity formation. Now these cavities are pulled with TB bacilli. Cavity will have communication to a bronchus. Whenever patient coughs from the cavity, TB bacilli will come into the bronchus. From the bronchus into the trachea. From the trachea into the atmosphere. So this patient is a very highly infective form. So he can transmit the disease, highly infective form. And this is active disease. And if you don't treat this patient, there will be very frequent complications. So this is an active disease, and if you don't treat this patient, there will be frequent complications. So what are the frequent complications? So this cavity can erode a blood vessel, resulting in hemoptysis. So patient can develop hemoptysis. The reason cavity can erode a blood vessel. Now this cavity can grow and rupture into pleural space. If all that necrotic material and TB bacilli go into pleural space, there will be pus formation, and this is called as empyema. And if only air escapes into the pleural space, air in the pleural space, it is called as pneumothorax. So what is the reason? Cavity can rupture into pleural space. TB bacilli can directly damage the bronchus, resulting in bronchiectasis. All these extensive TB lesions can heal ultimately by forming dense fibrosis. Whenever the lung is undergoing fibrosis, it cannot expand properly. So once it is not expanding properly, it cannot accommodate oxygen. So this patient will land up in hypoxemia. And hypoxemia in long run can cause pulmonary hypertension, ultimately resulting in cor pulmonale. So pulmonary hypertension ultimately resulting in cor pulmonale. So these are some of the important complications. So there can be hemoptysis. There can be development of empyema, pneumothorax, bronchiectasis, fibrosis, hypoxemia, pulmonary hypertension, cor pulmonale. So primary TB frequently seen in mid and lower zones, whereas secondary TB, it is seen in apex. Most important in primary TB is the presence of primary or Gons complex. Most important in secondary TB is cavity formation. Primary TB, very rare complications. So what are those rare complications also we will discuss. Whereas secondary TB, we have frequent complications as listed below. Frequent complications as listed below. Now I'll show you an image. So by this you can understand what is primary TB, what is secondary TB. So this patient was never infected with TB bacilli. Now for the first time TB bacilli are entering his body. So you can follow this. You can see TB bacilli entering his body. So they will reach the areas of high ventilation, mid and lower zones, and to fight against this. So they fight against this. There will be hilar lymph node enlargement. You can see TB bacilli reaching mid and lower zones, and there will be hilar lymph node enlargement. So this combination is called as Gons complex. Gons focus with hilar lymph node enlargement. It is called as Gons complex. So nothing to worry here. In majority, there will be spontaneous healing, so no need to worry. But in few, there can be rare complications. So what are those rare complications? And in these patients, if they ask you what will be the presentation, so there will be no or very mild fever. Occasionally, they can complain of pleuritic chest pain. No or very mild fever. Occasionally, they can complain of some chest pain, chest discomfort. Now coming to the rare complications of primary TB. So first complication is in few patients, what happens is the size of this lymph node. So this size of this lymph node can enlarge very much, compressing the bronchus beneath it. So there can be enlarged lymph nodes, and it may compress the bronchus. So enlarged lymph nodes compressing the bronchus. And usually the right hilar lymph node is involved. So in few patients, because of exaggerated lymph node enlargement, it can compress the right middle lobe bronchus. So there will be right middle lobe collapse because at the hilum you have right middle lobe. Now that bronchus is getting compressed. So normally bronchus will be open like this. Now above the bronchus, a big lymph node is compressing the bronchus. So bronchus will undergo collapse. So there will be right middle lobe collapse. So because of right middle lobe collapse, secretions can pull up. Later there can be infection, inflammation, destruction and dilatation resulting in bronchiectasis. So this is also called as Brock's syndrome, which I have already discussed in the topic bronchiectasis. So first important complications, enlarged lymph node might compress the bronchus resulting in right middle lobe collapse and bronchiectasis. And second important complication, few TB bacilli can reach the periphery of the lung, irritate the pleural surface and result in pleural effusion. So second important complication. So TB bacilli can reach the pleural surface, irritate the pleura and result in accumulation of fluid. Pleural effusion can be seen. Pleural effusion can be seen. Now, if at all this patient is already immunocompromised, so first time at the time of first infection itself, patient was severely immunocompromised. There was very less immunity. So in absence of sufficient acquired immune response, so there can be dissemination. Now this TB bacilli, because there is no immunity stopping it, it can spread to various parts of the lung. You can see in this image. Now this TB bacilli is spreading to various parts in the bilateral lung fields. So these are the three important complications that you should know in primary TB. There can be right middle lobe collapse with bronchiectasis. There can be development of pleural effusion. You can see right middle lobe collapse, bronchiectasis, pleural effusion, and this is dissemination. The TB bacilli going to most parts of the lung and it can cause damage to the lung if the patient is not having immunity. So this completes the primary TB. Now coming to this picture, this patient was already infected once in his lifetime, somewhere in his childhood. Now when he becomes adult, so later in his old age, his immunity has decreased. So whenever his immunity decreases, now the TB bacilli will start proliferating and they can reach to the apex. So once they reach to the apex, there will be areas of destruction called as cavities. So what is this type of TB? It is secondary TB, also called as post-primary TB. So secondary TB, also called as post-primary TB. So secondary TB, also called as post-primary TB. So whenever there is some derangement of immunity, so TB bacilli generally start again actively growing. So where they actively grow? In the apex, because apex are the areas with high oxygen tension. So this phenomena is called as secondary or post-primary tuberculosis. Now in this image, what you can see, there is right hilar lymph node enlargement. So all these are suggestive of primary tuberculosis. So this is how primary TB heals. So the parenchymal focus is getting healed and ultimately getting calcified. And all those enlarged lymph nodes can also be calcified later. So primary TB in majority no issue, so they will heal spontaneously. Whereas secondary TB, now can you notice upper zone infiltrations with areas of destruction. So what are these areas of destruction? Nothing but cavities. So what is this? This is secondary TB, also called as post-primary tuberculosis. Secondary TB, also called as post-primary tuberculosis. Also called as post-primary tuberculosis. Now coming to TB pleural effusion. So this TB pleural effusion occurs either as primary tuberculosis or secondary tuberculosis. So pleural effusion can happen either in primary TB or secondary TB. And in majority, it is due to hypersensitivity. So to TB bacilli. In the pleural membranes. So what is happening here? Consider this is the lung. Around the lung, you have a good pleural covering like this. So around the lung, very closely attached to the lung. So you have pleural covering. Like this. Now, why is pleural effusion happening? So these TB bacilli, reach the pleura. So they will be in the pleural tissue. So once these TB bacilli reach the pleural tissue, it can cause a hypersensitivity reaction. So because of that hypersensitivity reaction, fluid will start accumulating. So point to be noted here is majority of the TB bacilli will be residing in the pleural tissue, and fluid is just an hypersensitivity reaction. So TB bacilli in majority will be in the pleural tissue. So they will be very less seen in the fluid. So TB bacilli resides in the pleural tissue, and this fluid is just an hypersensitivity reaction. Now if you see the important features of TB pleural effusion, it is exudative pleural effusion because it is an hypersensitivity reaction. Some inflammatory phenomena generally will be exudative, and the inflammation in TB is usually mediated through lymphocytes. So there will be lymphocyte predominant pleural effusion. And next important thing is here ADA levels, adenosine deaminase, will be more than 40 international units, and also interferon gamma will be more than 140 picogram per ml. So this ADA, adenosine deaminase, and interferon gamma, so whenever body is fighting against TB, there will be some substances released. So one such substance is ADA and other substance is interferon gamma. So if you find ADA and interferon gamma in excess in that fluid, it means body is actively fighting against TB, and the chances of tubercular pleural effusion is very high. And if I take this fluid and look for TB bacilli by acid fast staining, so pleural fluid reveals acid fast bacilli in only 20 to 30% cases. As I told you, this TB bacilli are not residing in the fluid. They are residing in the pleural tissue. So in the fluid, there will be very, very less TB bacilli. You can only identify in 20 to 30% cases. Then what is the gold standard test to identify tubercular pleural effusion? So gold standard is generally taking the pleural tissue. So what I am going to do, I am going to do a pleural biopsy. So pleural biopsy, either you can do by a needle or more advanced is thoracoscopy. So I am going to do a pleural biopsy. So once I do a pleural biopsy, what is going to happen? I am going to pull out the pleural tissue. So pleural tissue will be containing TB bacilli. So for any infection, whenever it can be cultured, it will be the gold standard test. So pleural biopsy, and you have to take that tissue and you have to send it for culture for Mycobacterium tuberculosis. So collect the pleural tissue and you can send the pleural tissue for culture. So if at all in that media, if the TB bacilli is growing, it means that tissue has contained TB bacilli and it is gold standard for diagnosis. But generally, this biopsy and culture for MTB, it will take some time. So indirectly, how do I identify it as a TB pleural effusion? By seeing the ADA value and interferon gamma. So if they ask you, how do you routinely diagnose TB pleural effusion? So with the help of ADA, interferon gamma, lymphocyte predominant pleural effusion. But if they mention what is the gold standard, you collect the tissue by doing a pleural biopsy and send that tissue for culture. So if that culture grows Mycobacterium tuberculosis, it is gold standard test. Coming to TB HIV, it is just like Thanos getting all the stones. So it is a double trouble. So TB HIV, it is a double trouble. So TB HIV is a double trouble. Now what they are going to ask you in your exam is, now suppose you have seen a patient in the morning. So he is complaining of fever, cough, weight loss, all these classical features. So what do you suspect in this patient? Tuberculosis. So whenever you suspect it as tuberculosis, according to the new guidelines, you should not only evaluate for tuberculosis, you should also see whether this patient is having any HIV. So you have sent him for HIV test and also his sputum smear examination. So by afternoon, his sputum was positive for TB bacilli and he was also HIV positive. So by afternoon, now you have identified two conditions, TB, HIV simultaneously. So this phenomena is TB HIV co-infection. Now what to start in this patient first? Is it ATT, anti-tubercular therapy, or ART, antiretroviral therapy? So definitely, because this patient is having both TB and HIV, he needs treatment for those diseases. But if you start these two treatment together, there might be some side effects in the patient, not allowing him to continue the treatment. So to avoid these side effects, what we are going to do and what is the most important side effect that you should know. Now consider this patient is having two diseases. So TB, I will tell in terms of increased bacillary load and HIV in terms of decreased immunity. So this patient's immunity is low and within his body TB bacilli has increased. Now suppose if I start ART in this patient, antiretroviral therapy. So once I give antiretroviral therapy, it can damage the virus. So suddenly patient's immunity or CD4 count will increase. So there will be immunity getting reconstituted. Now this reconstituted immunity will see this TB bacilli and it will give an inflammatory response. So because of this inflammatory response, this patient will again develop some fever, lymphadenopathy, and he will stop taking the treatment. See, the most important thing in prescribing TB treatment and HIV treatment is not just writing the prescription. You should make sure patient is continuing the treatment for the given duration without having any side effects. So if at all patient initially only gets some fever and lymphadenopathy, he will stop taking the treatment and he will run away and he will go on spreading the society the disease. So what is happening if I give ART first? So once again understand here. So HIV in terms of low immunity, TB in terms of high bacillary load. So whenever I give ART, the CD4 count will increase. So immunity is getting reconstituted. So because of this reconstituted immunity, it is going to give an inflammatory response on the TB bacilli. So this phenomena is called as IRIS, Immune Reconstitution Inflammatory Syndrome. So write down, if ART is started first, if ART, antiretroviral therapy, is started first, there can be immune reconstitution, inflammatory syndrome, also called as IRIS. So what I am going to do is, I will start first ATT. Now if you give anti-tubercular therapy, what is the benefit? Again the same scenario. HIV in terms of low immunity, TB in terms of high bacillary load. So now if I start ATT first, so these drugs will go and damage the TB bacilli and gradually the bacillary load will come down. Now after 2 weeks to 2 months, if I start ART, even though the immunity is getting reconstituted, it is not having sufficient TB bacilli to give that inflammatory response. So this IRIS will not happen now and patient will settle without major side effects. So what I am going to do, I will start ATT first. And merge ART within 2 weeks to 2 months. Within 2 weeks to 2 months. So very, very important. If ART is started first, what is the dangerous event that can happen? IRIS. So what I do, I start ATT first and later ART is merged in 2 weeks to 2 months. Now suppose there was a patient with HIV already. So he was having HIV. He was on treatment. But unfortunately, because of opportunistic infection, he has developed tuberculosis. Now, what TB drug can be given and what should be avoided? You must be knowing ART and ATT have drug interactions. What is one drug? In ATT that has significant drug interactions? It is rifampicin. So when to give rifampicin, when to avoid rifampicin. Now suppose there is a HIV patient who is on ART, now developed TB. So when should rifampicin be given and when it should be avoided? Suppose if patient is on conventional TLE regimen. So TLE means tenofovir lamivudine efavirenz. So this is generally the routine regimen given in our country. If patient is on the routine regimen, rifampicin can be given. Rifampicin can be given. Now suppose if patient is on nevirapine protease inhibitor based regimen. Nevirapine protease inhibitor based regimen. Here rifabutin given instead of rifampicin because rifampicin has significant drug interactions with nevirapine and protease inhibitors. So point to be noted here is, so this is a red colored warning. So don't give rifampicin in combination to nevirapine protease inhibitor. So if the patient is on routine TLE regimen, you can happily give rifampicin in ATT. If he is on nevirapine protease inhibitor, don't give rifampicin. What can be given? Rifabutin can be given. Next update in TB HIV is, suppose there was a HIV patient. He was not at all having any symptoms. So nowadays in HIV, TB is very, very common. So even though HIV patient is asymptomatic, you should give him some drug to prevent tuberculosis in him. And or else HIV patient who is symptomatic, suppose he is having some fever, cough, and you have done all tests, and in all the tests the TB has been excluded. So in them also you should give a drug to prevent tuberculosis. So what is the drug? Isoniazid. So write down the new guideline in TB HIV. So in asymptomatic HIV, so in all asymptomatic HIV patients and in whom active TB is ruled out, they should be provided with isoniazid prophylaxis. So isoniazid prophylaxis. So it is called IPT, isoniazid preventive therapy for 6 months. So now you find a HIV patient. So HIV patient who is either asymptomatic or in whom active TB is ruled out. Active TB is ruled out. If there is active TB, according to the drug susceptibility pattern, so I have shown you the algorithm, you start treatment. So if the patient is not at all having any symptoms, or he was having symptom but you have ruled out TB, so in all these patients, isoniazid preventive therapy should be given for 6 months. So this is the new guideline. In all asymptomatic HIV patients and those in whom active TB is ruled out, they should be offered isoniazid preventive therapy for 6 months. Isoniazid preventive therapy for 6 months. Now, what is the difference in presentation of TB in HIV? So, if at all patient is having some amount of still persisting CMI, so in the initial stages of HIV, if the patient is affected with tuberculosis, it will be similar to the tuberculosis happening in general population. So it is the statement given here when the CMI is only partially compromised. So this actually happens in initial days of HIV, initial stage of HIV. So the pulmonary TB presents in a typical manner. So same as the pulmonary TB that we see in adults general population. So there will be cavities. So there will be cavities. So there will be cavities. In late stages where the immunity is very less. So it appears like a primary disseminated TB that I have shown you as a rare complication of primary TB. So a primary TB like pattern. So there can be some interstitial infiltrates, little or no cavitation, pleural effusion can be seen, and lymph nodes may be very big. So we have discussed the complications of primary TB. So in complications of primary TB, whenever body's immunity is not sufficient, there will be dissemination of TB and there can be pleural effusions formation and the complication of primary TB, intrathoracic lymphadenopathy can also be seen. So if you see a HIV patients in initial phase, there can be routine presentation of TB with the cavities. But if you see in late stages, so it will be like primary disseminated TB or primary progressive TB with those big lymph nodes and pleural effusions and also disseminated lesions. So there can be interstitial infiltrates, so bilateral infiltrates, little or no cavitation. Now you can see on the X-ray here. So this was a HIV patient. Initially, his CD4 count was more than 200. So there will be typical presentation. So what is a typical presentation? Upper zone cavity. So you can see upper zone cavity, upper zone cavity. So HIV patient with CD4 count less than 200. So it means it is in late stages where the count has decreased. So where the count has decreased. So now what is going to happen in these patients? What will happen in these patients? It will be like a primary disseminated TB. So you can see the infiltrates here. So without cavitations, so seen in the mid and lower zones. So if you don't treat this patient properly, so this was the initial X-ray. If you haven't treated him, what can happen? So all other complications. Soon it will disseminate throughout the lung. So you can find pleural effusions. You might notice big lymph nodes. So in a HIV patient with preserved immunity, there can be cavitary TB. So in a HIV patient with less immunity, what can happen? There can be primary disseminated TB like presentation. Interstitial infiltrates, cavitations may not be seen, pleural effusions can be seen, intrathoracic lymphadenopathy can happen. Now coming to the disseminated TB. So disseminated TB can be classified into two types. So we have classical miliary TB and other is cryptic miliary TB. So cryptic means something hidden. So cryptic means something hidden. So why it is called as hidden miliary TB, I will discuss later. So disseminated TB. So we have two types, classical miliary TB and cryptic miliary TB. So this classical miliary TB, so it can occur either as primary tuberculosis or secondary tuberculosis. So it can happen either in primary form or secondary form. So this is due to hematogenous dissemination. This is due to hematogenous dissemination of TB bacilli. So consider this is one alveolus, this is another alveolus. and in between alveolus there is interstitium which can contain blood vessels. Here the TB bacilli first will reach the alveoli, but because of some unknown reason all the TB bacilli will migrate into interstitium. So from the interstitium they go into the blood vessel, and from the blood vessel they can spread to various parts of the body. From the air space into the interstitium, from the interstitium into the blood vessel, from the blood vessel to various parts of the body. Now if I do sputum examination, sputum for acid-fast bacilli will be negative. So why will it be negative? Because these TB bacilli are not residing within the alveoli. They have migrated into the interstitium. So if you collect the patient's sputum and see within the sputum, there will be no acid phase bacilli, acid fast bacilli. And next important thing is, if you do eye examination, in few patients it can reveal, eye examination can reveal choroidal tubercles. Presence of choroidal tubercles is considered as a characteristic feature of classical miliary TB. Eye examination can reveal choroidal tubercles. And if somebody takes an X-ray here, one can notice bilateral, symmetric, diffuse. The size is very important. 1 to 2 mm. Millet-shaped shadowing. 1 to 2 mm. Millet-shaped shadowing. So this phenomena is called as the classical miliary pattern. So this is regarding this type. Now coming to cryptic miliary TB or hidden miliary TB, let us try to understand this with an example. Here patient generally will be elderly. So this patient will be elderly and he will be having some chronic symptoms such as fever, weight loss, anemia. Whenever an elderly patient reaches to me with fever, weight loss, anemia, what will be my differential diagnosis? So it can be either malignancy or some chronic infection such as tuberculosis. So tuberculosis, it is very easy to diagnose because you are having some sputum test, chest x-ray, all those. So first I try to rule out tuberculosis. So what I am going to do, I will examine his sputum for acid-fast bacilli. Sputum for AFB will be negative in this patient, and his chest X-ray was absolutely normal. Because AFB is negative and chest X-ray is normal, I feel I have ruled out tuberculosis and I will be investigating for some other disease. But one day what happens is patient collapses and there will be death. So there is collapse of the patient and that can result in death. Now I have been evaluating this patient, but still death happens. Now I wanted to know what caused the death. So I performed an autopsy. So autopsy in these patients reveals meningeal tubercles suggestive of disseminated miliary TB. Now what is this? Patient's chest X-ray was normal and AFB is negative. But autopsy is showing meningeal tubercles similar to disseminated miliary TB. So what has happened in this patient? So in this patient also there is miliary tubercles, but those tubercles were very very small, so I could not identify on chest X-ray. To be visible on chest X-ray, the size of the tubercle should be 1 to 2 mm. So this is also miliary TB. This is also miliary TB, but hidden on chest X-ray. But hidden on chest X-ray. So because it was hidden on chest X-ray, the name is cryptic miliary TB. So because of the small size of the nodules, you weren't able to see on the chest X-ray. Now my question is, how to identify this type of TB before a complication can happen? Now here AFB is negative, chest X-ray is normal. Still, if you are having a doubt, perform a CT chest. Chest X-ray might be normal, but CT chest definitely will show miliary nodules. So in the question, if they mention chest X-ray is showing miliary pattern, CT is also showing miliary pattern. So the diagnosis is classical miliary TB. If you can clearly see it on the chest X-ray itself, it is called classical miliary TB. Chest X-ray is normal, but CT chest is suggestive. It is cryptic miliary TB. Now you can see in the first image in the chest X-ray, top to bottom, side to side, 1 to 2 mm millet shaped shadowing. So this is classical miliary TB. You can see it very well. I am zooming the image. See, whitish areas, millet shaped shadowing. Same thing you should try to identify even on the CT chest. See here on the CT chest, 1 to 2 mm millet shaped shadowing. So all these are suggestive of classical miliary tuberculosis. Now coming to the treatment, first let us start with drug sensitive tuberculosis. So in drug sensitive tuberculosis, we have a new case, other is previously treated case. A new case, other is previously treated case. So according to the new guidelines, let it be a new case or previously treated case. If it is drug sensitive TB, the regimen will be the same. 2-HRZE plus 4-HRE. So it is initially 2 months off. H means isoniazid. R means rifampicin. Z means pyrazinamide. E means ethambutol. So initially 2 months of 4 drugs. Next 4 months we give isoniazid, rifampicin, ethambutol. So the total duration is 6 months. According to the new guidelines, let it be the new case, previously treated case. If it is drug sensitive TB, the regimen and duration will be the same. So regimen is 2-HRZE plus 4-HRE and duration is 6 months. Now coming to drug resistant TB. So first resistant TB that we come across is isoniazid monoresistant TB. So TB bacilli is only resistant to isoniazid. Isoniazid mono resistant TB. So what was the conventional regimen? HRZE. Now H has become resistant. So I am removing H and I give 6 months of instead of H, levofloxacin plus rifampicin plus pyrazinamide plus ethambutol. So just I have removed isoniazid and I am continuing the treatment for 6 months, including levofloxacin. Now, what is the treatment for MDR-TB? What is meant by MDR-TB? MDR means multi-drug resistant TB. Multi-drug resistant TB. Multi-drug resistant TB. So before going into this regimen, so what will be the regimen for rifampicin resistant TB? So let it be MDR TB or rifampicin resistant TB. According to the new guidelines for both, the regimen will be the same. So what is the reason? So what is the definition of MDR TB first of all? MDR means resistance to both H and R, isoniazid and rifampicin. Now, why the regimen for rifampicin resistant TB and MDR TB is the same? As I told you earlier, rifampicin is the most potent first-line antitubercular drug. So whenever TB bacilli has become resistant to rifampicin, it means high chances of resistant to isoniazid also. So if it is rifampicin resistant TB or MDR TB, the regimen and duration will be the same. So what is the conventional regimen or longer MDR TB regimen? So there is also a shorter regimen, but that shorter regimen has some exclusion criteria. First we will discuss the longer regimen, then we will go into the shorter regimen. So longer regimen, it is given for 18 to 20 months. So what are the drugs included? We give bedaquiline, cycloserine, clofazimine. So bedaquiline, cycloserine, clofazimine, levofloxacin, linezolid. And point to remember here is, in this regimen, this bedaquiline should be stopped after initial 6 months. So bedaquiline generally stopped after 6 months. So in the initial 6 months, we give bedaquiline plus cycloserine, clofazimine, levofloxacin, linezolid. From the next month onwards, we only give cycloserine, clofazimine, levofloxacin, linezolid. So this is the regimen for MDR-TB. Now coming to regimen for XDR-TB. So what is meant by XDR-TB? It is extensively drug-resistant TB. Extensively drug-resistant TB. It means it is an MDR TB that becomes resistant to 1 fluoroquinolone, that becomes resistant to 1 fluoroquinolone and 1 second line injectable, that is aminoglycoside. So 1 second line aminoglycoside. MDR was resistance to both H and R. XDR, it is an MDR TB that becomes resistant to one fluoroquinolone and one second line aminoglycoside. The definitions are very, very important. Now, what will be the treatment here? So, the treatment here will be 20 months. So, we should give it for 20 months. The drug regimen is similar. Bedaquiline plus cycloserine, clofazimine, levofloxacin, same drugs, line is only. But the regimen here is definitely given for 20 months. And as usual, bedaquiline stopped after initial 6 months. Stopped after initial 6 months. So now I have told you it has become resistant to fluoroquinolone. So we are giving still levofloxacin here. See, what we do is we are doing drug sensitivity testing. So second line LPA and also liquid culture drug sensitivity testing. So whichever fluoroquinolone is resistant, you will avoid that. You can give the next fluoroquinolone available. So for example, if levofloxacin resistant, so we can give moxifloxacin. Moxifloxacin given. If levofloxacin resistant, moxifloxacin can be given. So very, very important. You should know the duration of the regimens. It can be asked in your exam. Isoniazid monoresistant TB, the duration is 6 months. MDR TB, rifampicin resistant TB, the duration is 18 to 20 months. Whereas XDR TB, the duration is 20 months. XDR TB, the duration is 20 months. Now for MDR TB, so this is exclusively for MDR TB, not just a longer TB regimen. There is also shorter regimen given by the WHO, so which is routinely given in our country also. So write down WHO shorter MDR TB regimen. WHO shorter MDR TB regimen. The advantage, instead of 18 to 20 months, the treatment duration is 9 to 11 months. Treatment duration is 9 to 11 months. So what are the drugs included? Initially, for the first 4 to 6 months, we give high dose isoniazid plus ethambutol plus pyrazinamide, kanamycin, moxifloxacin, ethionamide, clofazimine. Along with that, for the next 5 months, we give ethambutol, pyrazinamide, moxifloxacin plus clofazimine. So these are the drugs we are giving here. High dose isoniazid, ethambutol, pyrazinamide, kanamycin, moxifloxacin, ethionamide, clofazimine. Along with that 5 months of ethambutol, pyrazinamide, moxifloxacin, clofazimine. I told you it is MDR TB, but still I am giving isoniazid here. So this is not routine dose, high dose. So studies have shown that whenever you give high dose of isoniazid in combination with other drugs, it was working well in drug-resistant strains. So this is the regimen, and what you should know, it is given for 9 to 11 months. That's why it is called as shorter MDR-TB regimen. But in all patients, you cannot give shorter MDR-TB regimen. There are some exclusion criteria. So this I have discussed in short. I told you there will be some exclusion criteria for shorter MDR-TB. So here let us see in detail. So if the patient is pregnant, I cannot give shorter MDR-TB regimen. If the TB is extensive to various organs, disseminated TB and CNS TB, so in these conditions, you need tuberculous therapy for longer duration for better improvement. And also there are no sufficient studies as of now to show the efficacy of shorter MDR-TB regimen in these patients. Now, if at all there is any documented resistance or intolerance or previous exposure to any second line drug in this regimen, you should not give this regimen. Suppose patient was treated with fluoroquinolones some 6 months ago for some pneumonia. So now what might have happened? This patient's body might have become resistant to fluoroquinolones. So that's why in India, because of high burden of tuberculosis in our country, we don't give fluoroquinolones empirically for simple pneumonias. So if there is a documented resistance, intolerance, or previous exposure to any second line drug in the regimen, we are going to avoid WHO shorter MDR-TB regimen. And patients with HIV who are having extra pulmonary TB. So still there are no studies to show the efficacy of this regimen in extra pulmonary TB in HIV. So we have data showing efficacy in pulmonary TB in HIV. Still we are not having sufficient data to show its efficacy in extra pulmonary TB in HIV. So these are some of the exclusion criteria: pregnancy, disseminated TB, CNS TB, resistance or intolerance or previous exposure of any second line drug in the regimen, extra pulmonary TB in HIV. So a brief revision. If it is drug sensitive TB, the duration is 6 months. Isoniazid resistant TB 6 months. MDR TB 18 to 20 months. XDR TB 20 months. So MDR longer regimen 18 to 20 months. Whereas MDR shorter regimen 9 to 11 months. And you have to exclude these patients while you are prescribing shorter MDR-TB regimen. Now coming to the new drugs helpful in treating tuberculosis. So we have bedaquiline, which is commonly used, and recently delaminide is also included in the program. Let us see some information. So this bedaquiline is a diarylquinolone group. So it belongs to diarylquinolone group. The mechanism of action is ATP synthase inhibition. Mechanism of action is ATP synthase inhibition. So it has an important side effect, QT prolongation, that is cardiac toxicity. Cardiac toxicity. And it should be used only in drug resistant TB. It should not be used in drug sensitive TB. So the dose of bedaquiline initially we give 400 mg OD. So later reduce it to 200 mg OD. Coming to delaminide, it is belonging to nitroimidazole group. Mechanism of action: mycolic acid synthesis inhibition. Mycolic acid synthesis inhibition. And side effect here also is cardiac toxicity called as QT prolongation. And this is also used only in drug-resistant TB. And the dose is about 100 mg BD. 100 mg BD. So these are the important characteristics of two new drugs, bedaquiline, delaminide. So these two drugs are routinely used in our country. More routinely used is bedaquiline. So bedaquiline diaryl quinolone group, ATP synthase inhibition, side effect QT prolongation, used only in drug-resistant TB. Dose is as given. Delaminide, nitroimidazole, mechanism of action, mycolic acid synthesis inhibition, side effect QT prolongation. This is also used only in drug-resistant TB. So recently, another drug has been approved in the treatment of tuberculosis called as pritomenid. So pritomenid is just like younger brother of delaminid. So pritomenid is just like younger brother of delaminid. So it also belongs to nitroimidazole group. The mechanism of action is the same, but pritomenid has a specific side effect. So P for pritomenid, P for peripheral neuropathy. P for peripheral neuropathy. Recently, there was a lot of buzz regarding pritomenid. So actually, because of COVID, so the buzz around pritomenid was not noticed. So this is the recent news. So the TB Alliance. So this is the union which does research for anti-tubercular drugs. So it has announced that there is authorization now in European Commission. So the new treatment regimen for highly drug-resistant tuberculosis, especially the XDR-TB. So the combination is only 3 drugs. So bedaquiline, pritomenid, linezolid. So it is called as the famous BPAL regimen. So write down the new regimen for XDR-TB is BPAL regimen. So it is combination of bedaquiline plus pritomenid plus linezolid. So still not yet routinely used. So recent trials have shown that these 3 drugs, in few patients were effective in treating XDR-TB. Still we need more studies to show its efficacy in all XDR-TB patients, but till then you can know the recent regimen for XDR-TB which is under consideration is BPAL. It is not yet routinely prescribed as the regimen that I have shown you previously. So this might be prescribed in the coming future after more evidence and studies. So this completes the recent updates and description of tuberculosis. So we have discussed the presumptive TB definition, detailed diagnostic algorithm, The clinical entities: primary TB, secondary TB, pleural effusion, TB, HIV, miliary TB, important radiological findings, and the treatment regimens according to the NTEP, National Tuberculosis Elimination Program. Coming to the respiratory workbook discussion. Now let us see the first image. So they have asked you to identify the image and the test. So this is a classical flow volume curve, also called as flow volume loop. And where do we get this? We get this on a spirometry. Now let us see what is this flow volume loop. So on a conventional spirometer, this is how it appears. So it is based on a graph. So it has two axes. On one side we have flow, on other side we have volume. So generally in spirometry, so we are going to see the expiratory flow. Now the patient has taken deep inspiration. Now he is forcibly exhaling the air. So whenever he exhales forcibly, initially there will be an highest velocity called as PEFR. Then later in the mid portion there will be an average velocity called as MEFR. So this highest velocity is called as PEFR. And in the mid portion there is an average velocity called as MEFR calculated. So this will be the normal flow volume curve during expiration. Good flow and good volume. Now if they ask you to represent inspiration, you must be knowing always expiration and inspiration will be in opposite direction. Always expiration and inspiration will be in opposite direction. Now this patient has good flow and volume during expiration. It means he has also taken his inspiration sufficiently well. So I am going to represent the inspiration on the opposite side, and it can be represented in this manner. So now it becomes a continuous structure. So good inspiration followed by good expiration. So this will become the normal flow volume loop. You can see good flow and good volume during expiration. Now, whenever there is an obstructive lung disease, so whenever there is an obstructive lung disease, so when there is some obstruction in your lung, whenever you are breathing out, you cannot breathe out with the same velocity or the same flow. So what happens is, in obstructive lung disease, there will be predominant decline in flow. So the PEFR and MEFR can be decreased. But if you give the patient sufficient time, he can still expel the volume out. So what you can observe in obstructive curve, the flow is predominantly declined. To call it as obstructive, the flow will be predominantly declined. The volume might be maintained. So if you give the patient sufficient time, so we have discussed in spirometry. So the spirometer can wait up to 6 seconds. A normal person can only exhale can exhale out completely in 3 seconds. But if required, a spirometer can wait up to 6 seconds. So in that duration, this patient can forcibly expel the volume out. Now what will be the character of inspiration? So as we discussed earlier in the pathophysiology of emphysema and also in airway resistance, I told you that inspiration is an active process whereas expiration is a passive closing process. So when there is an obstruction, it will be more pronounced during those passive process. So during the active process, your body is applying energy, it can overcome. So expiration, the obstruction is more pronounced. In the inspiration, it may not be that manifested initially. So inspiration, because it is an obstructive lung disease, so inspiration, it may not affect that much. So inspiration, inspiratory curve can be near normal. Inspiratory curve can be near normal. So point to be noted, to call it as obstructive, which parameter should be predominantly decreased? It is flow. It is flow. Volume can be maintained. Now coming to restrictive lung disease. So coming to restrictive lung disease. So restriction means that lung is not expanding. So because that lung has become hard, not expanding, so during inspiration, it is filled less. Because it is filled less, it can empty out less. So what happens in restrictive lung disease is, so this patient can generate the flow, but he cannot match the volume of normal lung. Suppose a patient's normal lung volume is 5 liters capacity. Restrictive lung will be only 2 liters capacity. So why he did not expel the volume out? Because he could not inhale properly, because his lungs are small. So he will inhale less, exhale less. So his inspiration is also affected. His inspiration is also affected. So to call it as a restrictive lung disease, which parameter will be predominantly affected? Volume. So in restrictive lung disease, the parameter predominantly involved is volume. In obstructive lung disease, the parameter predominantly involved is flow. So you can see these graphs and you can easily answer now. Now if you see in this image, so which parameter is predominantly involved? See, the flow is involved. So volume, not much change, and inspiration is also not much involved. So this will be an obstructive curve. So decline in height, you can see this is similar to this curve. So height is declined, volume not much altered. Whereas in this image, what you can see, so volume is predominantly decreasing. So this is a restrictive abnormality. So this is a restrictive abnormality. So the explanation is there here. If you notice this graph, see here, volume is decreasing. So the height not much affected. So here predominant decline in volume is restrictive. Predominant decline in flow, it will be obstructive. So for your exam, you should know the important shapes of normal curve, obstructive curve, restrictive curve. So now, so this obstructive curve, if you see, there is increased concavity of the curve. Whereas restrictive, this is of conical shape. So restrictive curve is having a conical shape, whereas obstructive curve is having increased concavity. Then a heavy smoker, what do you notice? What is the diagnosis? So this is the anterior portion, this is the posterior portion. So this is the classical increased AP diameter, and it is a barrel-shaped chest. Suggestive of hyperinflated lung fields seen in COPD emphysema. Then what do you see in the X-ray? So X-ray also you can see bilateral hyperinflated lung fields. So X-ray is showing bilateral hyperinflated lung fields, flat diaphragm, and tubular heart. So again, this is suggestive of COPD, usually the emphysema, hyperinflation, emphysema. So what are the findings? So we can notice hyperinflated lung fields, hyperinflated lung fields, flat diaphragm, flat diaphragms, tubular heart, tubular heart, hyperinflated lung fields, flat diaphragms, tubular heart. Next question, the patient is having chronic cough, unproductive sputum, diagnosis. So what do you notice in this CT scan? You can see dilated airways similar to parallel railway tracks. So this finding is called as tram track appearance. Tram track appearance. And in the history, chronic cough, productive sputum. All this put together, what is the disease name? It is bronchiectasis. It is bronchiectasis. So the answer for this question is bronchiectasis. Identify the ILD pattern. So in this ILD, you can see in the periphery of the lung, rounded areas of air. And how is this looking like? A honeycomb. So there is honeycombing, and honeycombing is characteristic of which pattern? Usual interstitial pneumonia. Usual interstitial pneumonia, called as UIP. So UIP of unknown etiology. It is called IPF, or idiopathic pulmonary fibrosis. Now this ILD, if you notice, this is only mild haziness. So this mild haziness, it is called as ground glass opacity. Ground glass opacity. And predominantly ground glass opacity, in which ILD pattern you see? NSIP. Non-specific interstitial pneumonia. Non-specific interstitial pneumonia. Once again, these two images are very, very important. Honeycombing, architectural distortion. If you find honeycombing, it is UIP. Whereas only mild haziness, ground glass opacity, NSIP. Identify the organism responsible. In this X-ray, you can see air bronchograms. So can you see air bronchograms? There is no significant shift of the trachea. So this is a consolidation localized to a lobe. This is called as lobar consolidation. Lobar consolidation is characteristic of which organism? Your answer should be Streptococcus pneumoniae. Lobar consolidation is characteristic of Streptococcus pneumoniae. Whereas in the next image, so actually all these images are on a background of pneumonia. So all these patients will be having clinical features of pneumonia. So pneumonia clinical features, and they might give you X-ray like this and ask you to interpret what might be the organism. So pneumonia, there is no much consolidation. You can only notice few haziness. So this is atypical pneumonia. So without consolidation, only haziness. So this haziness, it is called as interstitial pattern. interstitial pattern. Interstitial pattern, atypical pneumonia. And what is the most common atypical pneumonia? Your answer should be mycoplasma. See the difference between these two images. So in the first image, you can see a consolidation with air bronchogram occupying a lobe. It is lobar consolidation organism Streptococcus. Whereas here only mild haziness, interstitial pattern, most commonly mycoplasma. Now in this image, again you can notice a big consolidation. Because of the weight of the consolidation, normally horizontal fissure should be like this, but it has bulged down. So this phenomena is called as bulging fissure sign. You can see the horizontal fissure instead of being straight because of weight of the consolidation, it has bulged down. So this is bulging fissure sign. And in which pneumonia you can see this bulging fissure sign? Answer should be Klebsiella. So we can notice this in Klebsiella pneumonia. So here the organism is Klebsiella. Then what is the abnormality? You can notice an air-filled area. So there is an air-filled area and you can clearly make out the wall. Air-filled area with well-defined wall. So what is this called as cavity? Air-filled area with well-defined wall. Air-filled area with well-defined wall. Now, whereas in this image, this is also air-filled area. So this is also air-filled area, but I cannot make out the wall properly. So air-filled area with ill-defined wall. This phenomena is called as a pneumatocele. See the difference. Air-filled area, you are able to see the whitish area around it. So this whitish area is nothing but the wall of the cavity. It is well defined, so cavity. But here the wall is not well defined, it is pneumatocele. Sometimes cavity can have both air and fluid. So this is the cavity. It is containing both air and fluid. So what is this phenomena called as? It is called as lung abscess. See here. So it is containing air and fluid. I'll erase it so that you can notice. So this part is air. So this part is air. This part is air and beneath that fluid, and actually this is happening inside a cavity. So this is called as a lung abscess. So this is called as a lung abscess. Then identify the abnormality. So whenever they give you a chest x-ray with some unilateral disease or something like that, so see the position of the trachea. So the tracheal position is not much changed. And also heart shadow. Normally 1/3 will be on the right, 2/3 will be on the left. It is maintained. So it might be a consolidation. You can see a right-sided abnormality and there is no significant mediastinal shift. It can be a consolidation. So to call it as a consolidation, what you should notice? You should notice air bronchograms. Can you notice some air-filled areas here? Yes. So this is consolidation. This is consolidation. Consolidation. Now, the trachea is slightly going towards the left, and most important is the heart shadow here. So normally a heart shadow 1/3 should be on right. here heart shadow is not at all seen. Everything has shifted towards the left, and there is a density which is very white on the left. So density is on the left, and also mediastinum is being pulled towards the left. So it is a left pulling lesion, and such whitish density, homogeneous density is seen in airless lung field. So it is left-sided collapse. So it is a left-sided collapse. Now what do you see here? You can see some whitish heterogeneous densities on the right side. This is right lung, this is left lung. And the trachea is also pulled towards the right. You can see the right dome is coming up, the right lung volume is decreasing. So whereas left lung, it is expanded and maintaining normal volume, whereas right lung is decreasing. And the right side only trachea is also being pulled. So it is a right pulling lesion, but there is no homogeneous white as seen here. You can see here it is completely white. Here it is heterogeneously white, irregularly white. So all this is suggestive of an irregular process called as fibrosis. So you should be able to differentiate, right, fibrosis, collapse, and also consolidation. Consolidation, no shift with air bronchogram. Collapse, pulling lesion, homogeneous white. Fibrosis, pulling lesion, heterogeneous white. Now what is this? You can see a hypertranslucent area which is filled with air, 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 air. And adjacent to that, you can see a compressed lung margin. Can you see this compressed lung margin? And mediastinal shift towards the opposite side. So whenever you find these two in combination, hypertranslucent area, compressed lung margin, and also mediastinal shift, your answer should be pneumothorax. So this is a left-sided pneumothorax. Now what do you notice here? So the trachea is slightly going towards the left, and the heart shadow has extremely come towards the left. And on the right side, you are seeing a homogeneous density with a meniscoid fluid level. So there is a right-sided abnormality with push of mediastinum to opposite side, and it is homogeneous white with meniscoid fluid level. All this suggests there is right-sided pleural effusion. There is right-sided pleural effusion. See, effusion is fluid, so it will be homogeneous white, and there will be push of mediastinum to opposite side. Now in this image, you can notice fluid, and air. Because of these two, this is the compressed lung margin. There is fluid, air within the pleural space. So what is this entity called as? Hydropneumothorax. Presence of both air and fluid within the pleural cavity, it is a hydropneumothorax. Now they have given you some history. There was an young patient, acute pancreatitis. Later patient developed dyspnea. This was his chest X-ray. So acute pancreatitis, dyspnea, and in chest X-ray, if you notice, bilateral, top to bottom, side to side, there are diffuse infiltrates. Bilateral, diffuse infiltrates. And patient is having dyspnea, shortness of breath. and mostly because of this diffuse infiltrates, he will be having hypoxemia also. And the underlying condition is acute pancreatitis. So all this put together, this patient must have developed a dangerous complication in the lung called as ARDS. In pancreatitis, there is a systemic inflammatory response. When that inflammatory response reaches the lung and damages the lung, there can be development of acute respiratory distress syndrome. Now, a 75-year-old male, colon cancer, admitted in ICU, sudden onset dyspnea, chest pain, hemoptysis. Whenever you see a patient with malignancy or he is immobilized, he is in ICU means he is being on the bed only, bedridden, developing sudden onset dyspnea, chest pain, some amount of tachycardia, and you have taken a CT pulmonary angiography. So what is this structure? It is the main pulmonary artery. So within the pulmonary artery, normally blood will be there, which appears very, very white when I inject a contrast. Now in this area of white, there is a area of less white. So indicating some obstruction. So this is a thrombus. So what should be your answer? It is a case of pulmonary thromboembolism. So it is a case of pulmonary thromboembolism. It is a case of pulmonary thromboembolism. So what you can see on the CT pulmonary angiography, a thrombus in the pulmonary artery. Identify the procedure. So I have connected EEG, thoracic and abdominal belts to see the respiratory movements, and I have connected a flow sensor. So all this come under polysomnography. So EEG, ECG, EMG, EOG, thorax and abdominal movements, snore mic, oronasal flow sensor. So all this is nothing but polysomnography. In simple words, it is called as a sleep study. So what is this mission? This is nothing but a CPAP. So CPAP is medical management of choice in moderate to severe obstructive sleep apnea. So CPAP is continuous positive airway pressure. It is a type of non-invasive ventilation, so which delivers continuously positive pressure both during inspiration and expiration, keeping the airway open and preventing apneas, providing good sleep to the patient. So this completes the workbook discussion. So all the images. So all these were also discussed in your class notes. So once again, you correlate this images explanation with your class notes. You will not forget and you will learn better. So thank you so much. All the best.